Is ICU Conference. For anybody who's watched BoJack Horseman, you know what this clip is from. If you haven't, it's a very dark but excellent comedy on Netflix. Feel free to talk to me if you watch it. So let's jump into this case. Some of you are taking care of this patient now, so if you know what the final diagnosis is, don't give it away to your colleagues. But you are on your admitting shift and you get a call and you have a transfer from psych. So it's a 67-year-old female. She admitted for a suicide attempt. She tried to overdose on her benzos and her lithium. She was medically cleared and then sent to H2 for her psychiatry needs. She's been there for about 2 weeks. And this morning she had a new oxygen requirement and was a little bit more lethargic. So the psych resident is calling you to transfer this patient back to medicine for a workup. You can see her past medical history there. And then tell me what you guys want next when you're scanning her chart. Medlist? Okay, perfect. So for those of you on Zoom, I'm going to put Medlist up here. She has quite an extensive Medlist. It is 3 parts. And what I'm going to do actually for those of you in the room, it's almost like Claire was a plant. I'm going to pass out these medication lists. And what I want you guys to do is any medication you're unfamiliar with, I want you guys to look up what its mechanism is and just jot it down for the conference. I'm going to give you the middle table. Medlist 2. Just put it up. I'm going to give you guys Medlist 1. And then I'll give this final table Medlist 3. You guys can pass it down. So, just take about 2 minutes, and any medications you are unsure of their mechanism, look it up and just jot it down. And then for those of you on Zoom, if you have questions or need information, please feel free to send a question into the chat and I will respond.
That's faster. Typically outside of unrelated. Yeah. Sodium channels.
All right, I'm going to give you guys about another minute to keep looking stuff up. Are you guys good?
Yeah, we're good.
Okay, we'll start with you.
Okay.
All right, so let's wrap it up. We're going to start with table 3. And for those of you that walked in, you're on your admitting shift and you get a call from the psych floor saying that you have a transfer because the patient is lethargic and has a new oxygen requirement. We're looking at her medication list now. And so table 3, which medications did you guys have to look up and what did you find?
Words, yes.
Yeah, how does that work? Okay,
Entity, central altitude agonist.
okay, okay. So AED, acts on sodium channels, does not work on GABA. All right, anything else that you guys had to look up there? The rest of it's pretty familiar. All right, who wants to go next? Table 2? Okay, her eye drops. Okay, sympathomimetic. Anything else that's of note on that section? Yeah. Yep. Yep. So lithium, polypharmacy, any others in that column? She has what? Yep. So tryptan, history of migraines, and then she also has lorazepam as needed, benzo. All right, and let's go over to table 1. Anything on this list for you guys?
The benzo that's like a anesthetic for the cough reflex.
Yep. Okay. And then what else is like centrally acting medication on this side? Yep. For clobazam, alprazolam. Perfect. All right. So we've looked at her med list. And then the only new medications that were added, she had some antipsychotics for her stay on the psych unit for agitation. Any questions on the med list overall? The PRNs are listed at the bottom. So she was getting Haldol, quetiapine, and olanzapine as needed for agitation. All of the ones in her med list are stable medications that she's been on. And then the PRNs are obviously the new ones from her hospitalization. Okay, great catch, Claire. Looking at medications. Let's scroll down. So you appropriately asked for some vital signs, and we'll give you a physical exam. So blood pressure is 106/55, slightly tachycardic at 97. She's breathing fine. She's now on 2 liters to maintain her oxygen saturation, and her temperature is 99.1 degrees Fahrenheit. For her physical exam, the resident who examined her just noticed she was borderline tachy, dry mucosa. And then in terms of her neurologic exam, she's pretty sleepy, had to have vigorous verbal stimulation to be able to open her eyes. She's talking, but maybe not fully understandable, not able to follow complex commands, and then has this baseline rhythmic, low intensity movement of her mouth and lower extremities. Any other questions that you guys have for her physical exam? Okay, and then we're gonna jump into some more information. So on the psych unit, they don't grab labs every day. So we have some labs from 3 days ago. They had checked a BMP, which demonstrated an elevated creatinine. They checked her TSH and her lithium level. And so now you guys are getting ready to transfer her over. Take about 2 minutes with your table, and I want 3 things that you would order to work up this patient. All right, so you guys have had about a minute to talk about what you'd like to order to work up this patient. And so let's start with the middle table here, table 2. What are 3 things that you would order to work up this patient on her transfer to medicine? Yep. Okay, chest x-ray, ABG, or BBG. Table 3, what do you guys want? Okay, so chest x-ray, repeat lithium level, BBG or ABG. Table 1, what do you guys want? Perfect. Okay, so let me give you the labs that were actually checked by the person who was admitting her. So to give you guys some perspective, these were her labs on admission when she was first brought into the hospital. And then I will give you the labs that were checked in her acute illness. So I'll move these over here. I'll give you guys a minute to look at those. All right, anybody want to interpret these for me? Tell me what's changed. A new leukocytosis. No, it was not ordered before. Yep, AST on the left and ALT on the right. Okay. And then a UA was also obtained. Anything you guys want to comment on there? I know Dr. Ambruso talked about UAs and how to interpret them. So some blood, some granular cast. Here, what did granular cast make you think of?
Like intrarenal problem.
Okay, perfect. So maybe she's got some ATN. All right. Yep. Yeah, on the actual microscopy. Okay, and then somebody wanted a chest x-ray. So I will drop that in for you. All right, and so here's her chest x-ray. Take about 30 seconds, look at it with your teams. Remember, she has a new O2 requirement. She's a little bit lethargic, and then those are the labs that we just got. And then I'm gonna ask someone to help her interpret this, and you can again draw on the iPad and tell me where you think the abnormalities are once you've had a chance to review. Okay, any brave soul want to talk us through this chest x-ray? You always have backup. We have one of our pulm fellows here who can tag team in if you need help. So let's take a step back, and this patient is a little tacky, she's lethargic, she has a new oxygen requirement, she has many centrally acting medications. What's the diagnosis that you're worried about? Yeah, so does she have a new pneumonia? Does she have hospital-acquired pneumonia? Did she aspirate on something that made her hypoxic and have this leukocytosis? So what would you expect to see if someone had a pneumonia or an aspiration event on their chest x-ray? Perfect. Yeah, so we would expect to find a consolidation. Do we see a big consolidation anywhere? No. Anybody want to draw where they would expect to see a consolidation if someone had aspirated? Love it. Okay. Go ahead and just draw, make it red. Where do you expect to see something? Yeah, and what lobe would you be worried about?
Right lower, right middle as well.
Perfect. So, we're walking in thinking maybe this person has pneumonia, maybe they have an aspiration, but now you've gotten a piece of information that may or may not confirm your diagnosis. Questions on the chest X-ray?
Is her right upper lip not, because that looks fine. I can't really tell if it's like a weird bone shadow.
Like right here?
Yeah.
Yeah, I think that she's just kind of poorly rotated. Yeah. Our palm fellow, Megan, anything to add?
Yeah, I would probably say no acute abnormality chest X-ray. Right, almost looks streaky up in the right upper, which I don't speaking of a segmental collapse, like anaphylactosis, which does not fit your story. I agree with Dr. Duarte. She's just rotated. It's a super lordotic bone, so it's kind of shot, belly shooting up, and that'll make some of your shadows look a little funky.
Okay. No ABG was obtained on transfer, so those of you that wanted that, I apologize, you're not going to get it. I'm going to give you one last look at her lab, so go ahead, feel free to write anything down that you think is important that you might forget. And we're going to jump into our next part here. And so now at your table, what I want you to do is come up with a differential diagnosis, any additional things you're going to order for workup, and what you're going to do now as the person who's transferring her to medicine. For your differential diagnosis, you can list as many things as you'd like, but I want you to assign a % chance of each diagnosis. So if you really think that she aspirated, you can make that 100%. If you think there's other things going on, feel free to put them down. But I want you guys to think actively about what is most likely for this particular patient. So take about 2 minutes with your group, and then we'll come together and chat through each of the differentials. I will put her labs back up on the screen.
0 to 4. So you can do the blanket.
I don't know what's
All right, take about 30 seconds and wrap up your differentials. All right, so let's start with table one. Talk us through what your differential diagnosis was for this patient, and give me that specific breakdowns for each of your diagnoses. This table here.
I want to say we made it as far as perhaps. We talked about a lithium toxicity syndrome versus a like overdose.
Drug overdose?
We also talked about like acute infections that were on the list.
Okay.
Which like
Oop, there he is.
also with new mild tachycardia in the environment, he would be on the differential, but it won't explain a lot.
Okay. And if you had to say which one captured your interest the most, which one is most likely in your minds? Okay, like 60%, 100%? 70, okay. Great. Table two, what was on your list?
So we talked about like more generally, like some kind of toxicity, right? So we didn't come up with one in particular. It's probably most likely, you know, like with polypharmacy that we saw. But we also talked about Eeg as well. And we also talked about aspiration meningitis and how chest X-rays aren't super reliable acutely after the fact.
Great. Excellent point. Okay, and then which one was most likely at your table, the toxidrome? And what were you guys estimating? Okay, so maybe a 51%. Great. Table three, what did you guys come up with?
similar things. I think a couple other things that aren't on there. It's, I mean, I guess this is maybe the toxicrown, but just like the number of essentially active patients that are on as well. We discussed like whether she could be in status.
Yes. Great.
It's a little bit hard to like recognize status with that hypoxia, but like we just talked about rhabdo with the high AST.
Great.
Alex is always.
And then which one did you guys think was most likely?
I think similarly, we were thinking sort of like essentially active medication.
Some sort of toxic process? All right. Okay, and then anybody want any further tests to help figure out their differential, table one? Anything that you guys would want to check? Lithium level. Great, so we can get an updated level. Table two. Okay, do you guys want more time to chat and figure out what you do for workup and management at this moment? Okay, take about a minute with your teams. And now that we have our differentials, tell me what you would do to work up your primary diagnosis, and then what you want to take as your first step to stabilize this patient who's now hypoxic with an acute liver injury and a leukocytosis.
Okay, so. Yeah.
Okay, so let's revisit table 1, or you gave me something, we want to check a lithium level. Table 2, what do you guys want to check?
We discussed potentially also getting a lithium level. I don't know if there's a serotonin assay.
Okay, a serotonin assay,
CTE.
CTPE. Table 3, what do you guys want to check?
CT head, throat, blood culture, EKG. We probably get an EEG as well, CK, PPR.
CK. Oh, sorry, putting all these in the wrong place. Great, so maybe CTPE is worrisome. She has an acute kidney injury right now. We don't necessarily want to make that worse.
So they're not doing DET for legs as an initial.
Okay.
Yeah.
So maybe ultrasound for DVT bilaterally. Okay. So I'll give you guys some information. Her lithium level, 0.9. So not markedly different. Unfortunately, we don't have a serotonin assay. CTPE was not done for that same reason with her AKI. CT head was performed and it was normal, no acute abnormality, no bleed. Troponin, less than 0.015. Her blood cultures were obtained. They are in the lab. Nothing new from that yet. EKG was just sinus tach or sinus borderline tachycardia. She's about 97, 98. CK is in the lab. Her PVR was 0. And then ultrasounds for lower extremities were not done. So I'm going to let you know her CK comes back a little bit later in this case, but as do her blood cultures. But for right now, what are you going to do to manage this patient? And to sort of make sure we're all on the same page, a problem representation. So we have our 67-year-old female admitted to psych after a lithium and benzo overdose, who is now hypoxic and tachycardic with a new leukocytosis and acute liver injury, who's being transferred to medicine for further workup. So with that in mind, and the labs that you have, do you guys think we have to cover her for infection? Do we have to start her on a heparin drip for a PE?
Probably give her fluid.
Okay, so seniors want to give some IV fluids for her AKI. She looks dry on exam, so I think that's a great idea. What do you want to give?
A lot.
And at what rate?
I don't think she has any.
She has a history of a stress cardiomyopathy, but now has a normal EF. So just a bolus, 1 liter. Okay.
Yeah.
Does anybody want to start antibiotics?
We discussed it. I think it's like, I don't know, it's kind of a debate, right? Like she did febrile, she doesn't do oxygen requirements, no secretary didn't show anything. We're waiting on blood cultures. I feel like most people probably would start antibiotics because she's so undifferentiated, she's altered.
And then which ones would you start?
Yeah, she's we probably would just start broad, to be honest, like maybe.
Okay, so broad spectrum. Okay, she's been in the hospital for 2 weeks on the psych floor. Okay, anything else that you guys would do right now aside from giving her some fluids, putting her on a medicine floor, and then maybe starting those antibiotics?
If you're gonna start antibiotics, which I agree, like nobody to date has won the Nobel Prize for not administering antibiotics. So, but you never know, there's still time. But would you wanna take any other sources off the table before you antibiotics her? She's altered.
Yeah, I think we were talking about how concerned we were and like whether we would want medication.
Okay, Great. So thinking about that LP, she's altered, she has a white count, she's not febrile, but it's concerning enough. So maybe you're getting your supplies ready while everything is working.
I would hold essentially acting.
Great point. So holding, centrally acting.
As much as we're able to.
Yes,
I'd probably make her.
great. So we don't want her to aspirate more. If she is altered, we're gonna make her NPO. We're gonna hold her centrally acting meds. And as you guys saw, she had about 15 centrally acting meds on her list. So great idea.
Watch your urine output, make sure. it's
Yep.
not, like, 0.
Okay, so eyes and O's. And then what are you guys gonna do? So she has a known seizure history. If we're gonna stop all of her centrally acting meds, what are you worried possibly about? Yeah, so are you just gonna stop her seizure meds cold turkey?
Talk to.
Probably continue our example, it's not nothing.
Can we get a niacinamide level?
I don't think we have the capability for zonisamide levels, but I will say we can dose reduce it with her creatinine the way that it is. Okay, let's keep moving. So we have a great cross cover note. So that she gets admitted, she gets some antibiotics started, we're checking her eyes and O's, holding her centrally acting meds. And we get a cross cover note that says, at about 1800, I was called to bedside by 4 nurses due to concerns for overall clinical deterioration, specifically worsening somnolence, increasing rigidity in all extremities on neurologic exam and anuria. Vitals were significant for hypertension and sinus tachycardia. Temperature was 99.7. Labs revealed a serum CK of greater than 20,000, a rising serum creatinine to 2.3, and a K to 5.3. A Foley catheter was inserted, approximately 5 cc's of urine output over the next 2 hours. So with this additional physical exam and lab information, talk with your teams and tell me what's your updated differential with this new information, and then what's going to be your updated management for this patient. Let's take about 2 minutes and chat about it.
Yeah. Are you? Okay, take about 30 more seconds and wrap up your discussions. Okay, so I heard table 1 talking about some things. What are you guys worried about now in terms of your updated differential with this additional physical exam findings and then her CK coming back? NMS, do you want to maybe expand on that a little bit more for maybe folks who don't know what NMS is?
So she's on antipsychotics. She has a low fever, maybe she's rigid. She has a CK elevation. So hypertensive. So it looks like she could be reacting to that.
Sure. Okay. Anything else that table 2 is worried about? Okay, what's another thing that you have to think of when someone is altered and febrile with a white count? Sepsis, and more specifically?
Meningitis.
Great. Sepsis, meningitis. Table 3, anything else on your differential? Serotonin syndrome. So that SSRI that she was on, could be playing a role as well. Okay, anything else that people thought of in terms of what could be going on with this lady? All right, so now that we're concerned about these 3 things, what are some updated things y'all are gonna do to help manage her? Cool her down, love it. So cooling. Fluids. Yeah. What diagnosis can we give her with that CK? Rhabdo. Okay, and then we were holding her medication, so she's not getting more of her centrally acting stuff. Do you guys want to do anything about the potential for her meningitis? Seeing some people saying no. Seeing some.
No, but we should.
Yeah, no, but we should. My rule of thumb is if the question ever comes across your mind, like, should I do this LP? Should I do this procedure? The answer is probably yes, if you're thinking about it. So we should rule out any sort of infection. Okay.
I will say, I recall back to when I was an intern cross covering the old VA on a patient like this overnight who I was worried about, I was really worried about MMS. They were like bent over and rigid and febrile and stuff. And so I spent the whole night doing that, didn't give any antibiotics. And it turns out they were just septic. So yeah, I was good to not miss the sepsis.
Yeah.
It's done it once. So I guess the whole time.
So you guys have a great differential for this patient. And I would say that all 3 of these things are things, even if it's low on your priorities or like low on your likelihood, for all 3 of them still need to be treated urgently. So if it's on your differential, you should be doing something to treat it. For meningitis, for NMS, for serotonin syndrome.
We also get an EEG.
An ABG, EEG. And then what's the EEG going to tell us?
I think you're at risk of seizing for both serotonin and neural.
Perfect. And she has an underlying seizure disorder, and we've dramatically reduced her medications right now.
And then
So-
Like there's some rhythmic movement noted on her.
Mhm.
I don't really know what that was.
Yeah. Great. So
Try
all,
and demonstrate.
we'll have Carl do a demonstration in a minute. Okay. So we have the person here who actually transferred this patient or dealt with this issue overnight. So Carl was the resident who was on cross cover, his beautiful documentation. So Carl, I'm wondering if you could just sort of tell us, based on your exam of her, what was going through your mind as the cross cover resident, and how you approach the situation.
Yeah, so I would say kind of describing the exam findings a little more. I actually called it myoclonus when I first walked in and examined her. And I was also struck by how like the exam evolved over a period of a couple of hours. So what I will say is like first things first for me were like managing her rhabdo, seeing how quickly her mental status was going to deteriorate. And we were like on the phone with neuro and then eventually with the EU to see if this person needed to be transferred over there for continuous EEG. So like all those things rose to the top. But I think what I was really struck by on my second exam, on my first exam, that was like this diffuse myoclonus. And then on my second exam, kind of being down a particular path now, I was struck by like how really like rigid she was. The first time I examined, I was like, well, kind of maybe like a little bit of cogwheeling, maybe she's just not cooperating, or it's volitional. 2 hours later, she was like this, and at that point, we kind of went down that path.
Yeah.
And I think she also, like right as we were moving her to the ICU, spent a tap.
Mm-hmm. Yep, so you can tell us what was on your mind, what your
Yeah, I
leading
think so.
differential was.
Right, so, kind of as everybody has said, infection wasn't super high on my differential, but did definitely think about it, and ultimately did start broad spectrum antibiotics, it did make it seventy or so pretty broad. I was kind of initially going for NMS versus serotonin syndrome. She had reasons to have either or, and initially the exam was kind of, actually, I think Gardner came and some of it. We were like talking about it a lot, like which one was more likely. She was on swing, and then she signed out, and I went back, and then the patient was like this. I was like, this looks like NMS.
Yeah, so NMS is something that if you think your patient has it, you can't delay treatment because the morbidity and mortality is extremely high. So Carl did the exact right thing by saying, hey, I'm worried about this, and so I'm going to call people and treat her for it. He mentioned that there's a difference. Could it be NMS? Could it be serotonin syndrome? Do you all have ways that you differentiate between the two of those?
Reflexia versus hypergidity.
Yeah, so hyperreflexia, and that goes with which one?
Serotonin syndrome.
Perfect. So people with serotonin syndrome are usually hyperreflexic, they're usually ataxic, and they also have usually GI involvement before, so they're nauseous, they're vomiting. And the way that I sort of remember that is when you start somebody on an SSRI, those are usually the symptoms that are going to bother them the most. So I sort of pair it up that way in my brain. And then for NMS, you hit the nail on the head. So they have lead pipe rigidity, they're hypertensive, they're hyperthermic. And so this patient definitely was on way more of the medications that can cause NMS. So she probably had hundreds of milligrams of Haldol, quetiapine, and olanzapine when she was on psych. And then her use of lithium and Zofran are also implicated in NMS. So that raises your concern that somebody could have that.
I guess like two quick things to add, just like relevant to the differential information. So, thought about status epilepticus was like also, I kind of mentioned this first time, but was forefront in my mind as well. The exam was really less consistent with seizure activity, looked more like, again, myoclonus. She initially was like kind of responding to like forceful stimulation. So putting those two things together, it doesn't really look like status, but that's a diagnosis that can fool you very easily. And so, hence we were like trying to tee up the new CEG before she like really started to compensate.
Yeah.
So if you're worried about NMS, what are you going to do to manage somebody who has that? I heard some great talk here at table 1. Maybe they want to share some of their thoughts. Dantrolene, okay. Any other thoughts by the group? Dantrolene and bromocriptine. What else are you going to do to help support her? We mentioned cooling. Yep, so antihypertensives if they're spiking their blood pressure. Okay, so the most important thing that I cannot stress enough to you is you need to stop all of the offending medications. That is the thing that will help this person. It is very important to call toxicology. So they're the experts in figuring out if it truly is NMS or if it's something else. NMS needs to be pretty much a diagnosis of exclusion before you call it that. We generally have to control agitation for these patients. And so what medications can we use to control agitation in the ICU? Yeah, no, you're right. It's benzos. So this patient is going to get put on a Medaz drip to help control her agitation. Yes, so one would be intubated before you start them on a benzo drip.
Be ready.
Yeah, be ready to. So Megan's not going to be happy if you put somebody on a benzo drip and then you're like, oops, they can't breathe now.
Oh, yeah.
So what are you gonna do to control her temperature?
Tylenol?
Yep, so we can give Tylenol. She can't take anything by mouth, so how are you gonna give it? So you have PR, or you can give IV. And then I heard someone mention ice baths. Anything else that you would do?
Yep, so you can get them cool. You can just put some ice packs in, underneath their armpits and their groin. You can also put an NG tube and run ice cold water to help cool them down. For the complications, so people die of NMS because of the complications that come along with it. And the thing that we often worry about is blood pressure, their fevering, and then their rhabdo and renal involvement. So in terms of managing the complications, you're going to give them IV fluids, you're going to watch their volume status, you're going to make sure they're actually urinating. And then the rest of the things, we sort of talked about. The other issue that comes up is secretions. And so this woman was intubated for airway protection because she was having so many secretions that she just couldn't manage. So intubation. And then in terms of the medical therapy we can give, we mentioned dopamine agonists, which is your bromocriptine, and then muscle relaxants, which is your dantrolene. This patient has a contraindication to dantrolene as it stands based on her labs. So 2 organ systems that were deranged on her labs. Which ones? Liver and kidney. Take a guess at which one? Liver. It's hepatically cleared. So when Carl and the team called tox, they said, we don't recommend dantrolene because she has pretty bad AST, ALT elevation. So she got bromocriptine.
Full disclosure, what they said to me was, oh, we never use dantrolene. Which was a surprise. The times I was like, oh, no, not dantrolene.
AST elevation.
Or just AST elevation.
Which might,
Yeah.
there might be another teaching point there too.
Yeah, because that.
Yeah.
I think that's what
With the
That
rhabdo.
was all.
Yeah. Yeah. So that was mostly her rhabdo that was raising her AST. Okay, so we've done all this. You guys have stabilized her. She's intubated. She's on her Medaz drip. We've cooled her temperature, and she's getting bromocriptine. Anybody know how bromocriptine is dosed?
For pharmacy.
I didn't know either, but it's 2.5 milligrams Q6 hours, and you can escalate up to a total dose of 40 milligrams in a day. So she was started on that low dose. She was also sent over to the university eventually for continuous EEG monitoring to make sure she wasn't in status. She started having some rhythmic movements of her mouth and of her right arm, which is where her seizures typically were. The last thing that we didn't really touch on, but we will touch on quickly here before we wrap up, is figuring out if she's infected. So she spiked a temperature to 102 once she got to the ICU. She's altered. We really do have to do an LP to make sure that she doesn't have meningitis, because that also has very high morbidity and mortality associated with it. So I'm going to give you her CSF studies. Take about 30 seconds with your team and tell me what you're thinking.
Point 0.07 seconds. So it's hanging on for telling. It's like almost a little. It's an angel.
So Dr. Connors actually performed this LP. All right, so the thing that we're worried about with this patient is a bacterial meningitis. Does anybody have a good way that they think about CSF studies and how you diagnose bacterial meningitis? Seniors, how do you guys think about it? Okay, so for bacterial meningitis, low glucose, do you have a number that you use? Great. So we're going to look at glucose. What else do you look at? Protein, high or low? Okay. And then what else do you look at? Yeah, your cells and your differential. So I'll drop in the criteria that most people use. So white blood cell count about 1,000 to 2,000. Generally, PMN predominant, protein level greater than 200, glucose less than 40. And then while you're waiting for these studies to come back, because it takes time to get the patient set up, who knows what your empiric meningitis coverage is for somebody that you're worried about having a bacterial meningitis. What antibiotics are you going to select for this 67-year-old lady? Yeah, ceftriaxone,
Okay.
bank, ampicillin. Why do we give ampicillin to this lady? Yeah, she's greater than 50. And then acyclovir for viral. Seniors, do you guys have doses in mind of how you dose this medication? Because you'll be on overnight at 3 a.m, being like, where's that up-to-date article? So your ceftriaxone, how are you going to give it? 2 grams, perfect. How many times a day? Close. Q12. So it's a lot of ceftriaxone. Your vancomycin pharmacy will help you dose, but generally 15 to 20 mg per kg every 8 to 12 hours. And then your ampicillin for listeria coverage. Close. Let's give it to you guys. So this is your empiric antibiotic coverage. Acyclovir obviously for HSV, BZV. And then if you're worried that somebody is having a bacterial meningitis, it is important to also dose dexamethasone to help for morbidity and mortality outcomes. Questions on this? Does she have a bacterial meningitis? No, perfect. So antibiotics were discontinued after the LP, and acyclovir was discontinued once her HSV and BZV studies came back. So this patient likely had NMS. Toxicology was following. She went to the U for a brief period of time. She's back now, actually. And so I think Ben is the only person from his team here still, but she's actually on Ben's team.
Oh, yeah.
Yeah. So a lot has happened, since, and I think Justin might have taken care of her when she was on site. So.
Yeah,